Welcome to another episode from the Veterinary Medicine Digest. The landscape of veterinary neurosurgery is currently undergoing a profound and sophisticated transformation, moving away from traditional paradigms of extensive surgical exposures toward the refined and biologically respectful principles of minimally invasive techniques. To understand the significance of the research we are diving into today, we must first establish the foundational philosophy that governs minimally invasive surgery, which is to perform a surgical procedure with the absolute minimum amount of iatrogenic trauma possible. This objective must be achieved without compromising the primary goal of the procedure, whether that involves decompression of neural structures or the stabilization of an unstable vertebral column. In the realm of spinal surgery, these approaches require meticulous modifications in access strategies to navigate the complex and varied anatomical locations of the spine. Minimally invasive spine surgery in human patients has already provided a robust body of evidence demonstrating numerous clinical benefits, including significantly shorter surgery times, decreased intraoperative blood loss, reduced durations of hospital stays, and a lower incidence of surgical complications. The transition from traditional open approaches to minimally invasive strategies involves a shift from subperiosteal dissection, where muscles and tendons are elevated from their osseous attachments, toward muscle-sparing approaches. These muscle-sparing techniques are generally categorized as either intermuscular, which uses anatomically defined tissue planes, or intramuscular, which utilizes muscle-splitting techniques to gain a direct and efficient path to the area of interest. In human medicine, the standard for such procedures often involves the use of rigid tubular retractors and specialized instrumentation, frequently assisted by endoscopic visualization or high-quality operating microscopes. The biological impetus for these changes is grounded in the preservation of the soft tissue envelope and the maintenance of segmental innervation and blood supply. Research using magnetic resonance imaging to evaluate changes in paraspinal musculature after human lumbar surgery found significantly fewer negative changes, such as atrophy and denervation, in cases where minimally invasive approaches were utilized compared to traditional open procedures. For our veterinary patients, the benefits of such approaches are increasingly recognized, although the implementation is still in its relatively early stages. The goal in veterinary medicine is to decrease the undesirable effects of extensive tissue dissection, which may lead to impaired function of the local musculature and longer postoperative recovery times. Historically, veterinary surgeons have relied on the freehand technique to place pins and screws in the thoracolumbar vertebral column, a method that requires a deep understanding of morphometric landmarks and a reliance on tactile feedback. This approach is often characterized as a near-blind endeavor once the drill bit passes beyond the initial entry point, making the safety of the trajectory unpredictable and highly dependent on surgeon experience. To address these challenges, several advanced technologies have been investigated, including intraoperative neuronavigation and the use of three-dimensionally printed animal-specific drill guides. While three-dimensionally printed guides have demonstrated exceptional accuracy, they require significant preoperative planning and consistent access to sophisticated software and hardware, which may not be feasible for urgent cases, such as acute vertebral fractures or luxations. The search for a more accessible and efficient method for guiding spinal implants leads us to the critical role of intraoperative imaging, specifically fluoroscopy. In human medicine, fluoroscopy is the most commonly used imaging modality for identifying the appropriate access portal locations during minimally invasive procedures. In the veterinary field, the use of fluoroscopic guidance has been described for various applications, including the percutaneous placement of external skeletal fixators for vertebral stabilization, a clinical case series investigating lateral, minimally invasive percutaneous spinal stabilization, using a unilateral uniplanar external skeletal fixator with polymethyl methacrylate, demonstrated that this approach could be successfully applied to fractures and luxations with minimal major complications. However, the pursuit of more permanent and internal stabilization methods has led researchers to investigate percutaneous pedicle screw and rod fixation. This brings us to the core research paper of our deep dive today, an original research study authored by Francisca Couto and colleagues, titled minimally Invasive Percutaneous Cannulated Polyaxial Screw and Rod Fixation Thoracolumbar and Lumbosacral Vertebrae. Cadaveric Evaluation of Accuracy and Safety of Fluoroscopic Guided Technique in Large Breed Dogs. This study sought to develop and report the safety and accuracy of a technique for percutaneous pedicle screw and rod fixation using a fluoroscopic guided approach, specifically comparing the performance of experienced surgeons with that of an inexperienced resident. The methodology employed in this research was comprehensive and rigorous, utilizing the cadaveric vertebral columns of 3 large breed dogs, weighing more than 25 kilograms. The investigators first performed preoperative computed tomography scans to facilitate meticulous in silico surgical planning. Ideal implant insertion points and trajectories were recorded, and the images were subsequently reconstructed in a thick slab mode to mimic the appearance of intraoperative fluoroscopy, allowing the surgeons to visualize the intended path through the vertebral body or pedicle. This planning phase is crucial, as the safe and accurate placement of vertebral implants is technically demanding due to the variable morphology of canine vertebrae and the close proximity of critical neurovascular structures. The researchers utilized a 16-gauge Jamshidi needle to identify the ideal insertion point and to penetrate the cis cortex of the bone through a small 10mm stab incision in the skin and fascia. This was a critical modification from previous open techniques, as it allowed the entire procedure to be performed percutaneously without the need for extensive muscle reflection. Under intermittent fluoroscopic guidance, the Jamshidi needle was reoriented until its cross-sectional area appeared as small as possible on the monitor, ensuring it was perfectly aligned with the primary X-ray beam and the planned trajectory. Once the needle was docked and hammered into the cortex, the stylet was removed, and a 1mm sharp Kirschner wire was inserted into the medullary bone. A major component of this study was the feasibility evaluation of a commercially available system originally designed for human cervical and upper thoracic surgery. This system consists of cannulated polyaxial screws made of titanium, which can be inserted over a guide wire, and a specialized rod insertion tool that allows the passage of a pre-contoured rod through the muscle layers. The researchers demonstrated that this system was successfully applicable at both the thoracolumbar junction, between the 13th thoracic and 1st lumbar vertebrae, and the lumbosacral junction, between the 7th lumbar vertebra and the 1st sacral vertebra. At the lumbosacral region, the screws were placed in a converging pattern to ensure the rods could be passed lateral to the articular facet joints without impediment. The safety and accuracy of these procedures were determined by comparing the planned trajectories with the actual results obtained on postoperative computed tomography scans. The researchers measured angle deviations in degrees and bone purchase depth deviations in millimeters. To provide a standardized measure of safety, they utilized a modified Zdychowski classification system, which is a validated human grading scheme for assessing pedicle screw placement. In this system, grade 1 represents optimal placement, while higher grades indicate various degrees of cortical breach or potentially unsafe violations. The results of this study provided profound insights into the importance of surgical experience when performing these technically demanding procedures. The experienced board-certified neurologists achieved optimal drill hole placement in 82.4% of their attempts and did not drill a single unsafe hole. In stark contrast, the inexperienced resident achieved optimal placement in only 41.2% of attempts and drilled 4 holes that were categorized as unsafe, which could have resulted in significant spinal cord injury in a living patient. Statistical analysis showed that optimal drill hole placement was significantly associated with surgeon experience, while factors such as the specific cadaver or the spinal region did not reach statistical significance in the multivariable model. Furthermore, the experienced surgeons were significantly faster, taking an average of 2 minutes and 47 seconds to drill each hole, compared to 5 minutes and 21 seconds for the inexperienced resident. This finding has significant implications for clinical practice, as prolonged surgical times under fluoroscopic guidance would lead to increased radiation exposure for both the patient and the surgical team. Although exposure times in this study were kept to a minimum, the researchers emphasized that the learning curve for this technique is steep and that it should be reserved for surgeons with substantial experience in open instrumented spinal fixation. An interesting finding from the accuracy data was that bone purchase depth deviations were significantly lower for the experienced surgeons in the thoracic region, whereas the differences in the lumbar and sacral regions were not as pronounced. The researchers hypothesized that the thoracic spine might actually be easier for accurate guide wire placement because the rib head and the lamina overlying the pedicle provide a flatter surface compared to the more obliquely contoured bone of the lumbar vertebral bodies. In the lumbar spine, the Jamshidi needle may be more prone to slipping ventrally on the sloped bone surface during the initial penetration of the cortex. This study also highlighted the technical advantages of using polyaxial screws, which offer a high degree of flexibility during the construct assembly. Unlike traditional plate and screw systems, the heads of polyaxial screws, often called tulips, can be angulated and rotated to accommodate the trajectory of the interconnecting rod. This is particularly beneficial in a minimally invasive context, where the rod must be passed blindly through the muscle layers using a specialized inserter. The use of cannulated extension sleeves allows the surgeon to manipulate the polyaxial heads remotely and to seat the locking set screws with high precision. Despite the promising results, the investigators noted several limitations to their study. The research was conducted exclusively on large breed dog cadavers with normal vertebral anatomy, meaning the findings may not be directly applicable. Smaller breeds, different body sizes, or vertebral columns with significant pathological changes. Additionally, the study utilized drilled holes as a surrogate for actual metallic implants in most cases, which might have led to an underestimation of the potential for cortical breaches, as actual screws would have a larger diameter. Furthermore, more complex clinical conditions, such as displaced spinal fractures or cases requiring the removal of bone fragments from the vertebral canal, might still be better managed through a traditional open approach. The clinical significance of this research cannot be overstated, as it provides a feasible pathway for implementing internal spinal fixation in a minimally invasive manner in veterinary medicine. By reducing the need for extensive muscle stripping, this technique has the potential to preserve the dynamic stabilization provided by the paraspinal musculature, which is essential for the long-term functional recovery of the patient. Furthermore, the reduction in soft tissue trauma is expected to lead to improved patient comfort, reduced reliance on postoperative analgesia, and shorter hospitalization periods, mirroring the benefits seen in human medicine. Looking back at the broader context of minimally invasive fracture stabilization, we can see that this research fits into a larger trend within veterinary orthopedics. A review of minimally invasive osteosynthesis in dogs and cats found that while the technique is feasible and associated with low complication rates, there is a clear need for more randomized controlled studies to prospectively compare these methods with standard open approaches. The current evidence supports minimally invasive osteosynthesis as a promising modality that can yield excellent outcomes when applied in carefully selected cases by experienced surgeons. The importance of precise anatomical knowledge remains a cornerstone of these advanced techniques. Landmarks that are traditionally used in open approaches are often concealed beneath the skin and soft tissues in minimally invasive procedures, necessitating a reliance on palpation and intraoperative imaging to confirm the accurate placement of instruments. The high learning curve associated with these procedures is a recurring theme in the literature, emphasizing that surgeons must be prepared to invest the necessary time and training to master these techniques before applying them in a clinical setting. In addition to the surgical technique itself, the development of specialized instrumentation has played a critical role in the advancement of minimally invasive spine surgery. The evolution of angle-stable implants and locking plate systems has allowed for increased construct stability and the preservation of periosteal circulation by obviating the need for direct plate-to-bone contact. These technological advancements, combined with the increasing availability of intraoperative imaging and navigation systems, will likely continue to drive the growth of minimally invasive procedures in veterinary medicine. The radiation safety aspect of using fluoroscopy remains a significant concern for the veterinary surgical team. While the mean operative and fluoroscopy times in studies often decrease as surgeons gain more experience, it is essential to monitor cumulative doses to both the surgeon and the patient. In human medicine, Bindle and colleagues measured surgeon radiation exposure during minimally invasive transforaminal, lumbar, interbody fusion and found that while exposure levels were generally within recommended annual limits, they could be exceeded if a large number of complex procedures were performed. For veterinary surgeons, the use of lead aprons, thyroid protectors, and personal dosimeters is mandatory, and exposure can be further limited by rotating the C-arm to find the most efficient projection angle. An alternative to fluoroscopy that addresses the radiation concern is the use of three-dimensional intraoperative imaging, combined with optical tracking, as seen in spinal neuronavigation. This technology allows the surgeon to visualize the position of their instruments in real time relative to the patient's anatomy in multiple planes, effectively allowing them to see through the skin and soft tissues. Proof of concept study by Guevara and associates demonstrated that such a system could accurately guide the percutaneous drilling of screw corridors in the thoracolumbar spine of dogs. However, even with these high-tech systems, the study found a significant difference in accuracy between experienced and novice surgeons, particularly in the challenging thoracic region. The specific grading systems used to evaluate accuracy, such as the Zdechovsky classification or the Mobbs-Rayleigh grading system, are essential for providing objective data and for allowing comparisons between different studies. The Mobbs-Rayleigh system, for instance, categorizes screw placement based on the degree of cortical breach, with grade 0 representing a screw completely within the cortex and grade 3 representing a significant complication, such as a pedicle fracture or neurological deficit. These objective metrics are vital for defining the success rates of new techniques and for identifying areas where the learning curve is most pronounced. As we consider the future of veterinary spinal surgery, the research by Couto and her colleagues stands as a significant milestone in the adaptation of percutaneous pedicle screw and rod fixation for canine patients. Their work demonstrates that internal fixation can be achieved with high levels of safety and accuracy by experienced hands, even through minimal skin incisions. This study provides a rigorous framework for future in vivo clinical trials, which will be necessary to validate the potential benefits of this technique in terms of reduced pain, faster return to function, and decreased surgical site morbidity. The potential for this technique to be used in treating degenerative conditions, such as degenerative lumbosacral stenosis, is particularly exciting. In such cases, indirect neural decompression can potentially be achieved through vertebral stabilization alone, without the need for a traditional open dorsal laminectomy or foraminotomy. By stabilizing the lumbosacral junction in a slightly flexed position, the volume of the intervertebral foramen and the vertebral canal can be enlarged, relieving pressure on the nerve roots. This approach could significantly reduce the morbidity associated with what are often large and invasive standard procedures in large breed, overweight dogs. Furthermore, the adaptation of human surgical systems for use in veterinary patients continues to expand the toolkit available to veterinary neurosurgeons. As the availability of appropriately sized instrumentation increases, and as more veterinary centers invest in advanced intraoperative imaging technologies, we can expect minimally invasive spine surgery to become increasingly commonplace. The transition will require a commitment to ongoing education, as the adjustments from open to mini-open or percutaneous procedures involve substantial changes in visualization and surgical technique. The journey toward minimally invasive excellence is not merely about using smaller incisions. It is about a fundamental shift in our understanding of the biological impact of surgery. It is about leveraging the power of modern technology, whether through fluoroscopy, navigation, or patient-specific guides, to perform procedures with a level of precision that was previously unattainable. The work of these dedicated researchers provides a clear vision for the future, where the primary goal remains the healing and well-being of the animal, achieved with the lightest possible touch. In conclusion, the study by Francisca Couto and her colleagues has successfully demonstrated the feasibility and accuracy of percutaneous cannulated polyaxial screw and rod fixation in the canine spine using fluoroscopic guidance. Their findings emphasize that while the technique is safe and highly accurate when performed by experienced surgeons, the inherent learning curve is significant and must be respected. This research paves the way for a new era of veterinary spinal stabilization, offering a sophisticated alternative to traditional open techniques that has the potential to significantly improve the clinical outcomes and the quality of life for our canine patients. The future of veterinary medicine is indeed moving toward a more refined, precise, and minimally invasive horizon, where the preservation of biological integrity is as important as the mechanical success of the procedure. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.